Hello, and welcome to your lecture on pain and inflammation medications. Our objectives are going to be quite similar that we're going to see throughout the entire rest of the program relating to classifications of medications. So therapeutic effects, pharmacological action, common side effects, adverse effects, proper technique, drug knowledge, and administration, recognizing client education, and potential adverse reactions. So for pain and inflammation medications, we have quite a few classifications. When we go to other sections, there's going to usually be less classifications. So going through these, you're just going to need to know, like I've said before, like this class is crash course. There's a lot of information that's going to be being presented to you in a very short amount of time. For my class, what I want you to get from each one of these lectures topics is to align it to the classification. Every medication this semester, for even on your exams, if I list a medication name, I will give you the classification. So you do not have to worry about medication names at this time. Over the semesters, you will, through exposure to the medications, start to know and recognize names. But pretty much medications of the same classification have the same administration, adverse effects, side effects, things like that. So for the concept for this class, I want you to focus on classifications, okay? So we're going to go through non-opioid, opioid agonist, opioid antagonist, and then adjuvant medications for pain and other miscellaneous pain. So the first classification is going to be non-opioid analgesics. This is going to include NSAIDs and then acetaminophen. Acetaminophen, the brand name is called Tylenol, is not an NSAID. An NSAID means a non-steroidal anti-inflammatory drug. So by its drug name, it entails an anti-inflammatory response. That is the purpose of the medication. Acetaminophen or Tylenol does not help with inflammation. We need to know that difference here for later when we get into musculoskeletal. So with your NSAIDs, you have first generation, second generation. You don't need to know the difference in these. Just here's some examples. So first generation are the older medications, and second generation being the newer type medications. So aspirin, ibuprofen, which is also called Motrin, naproxen, also called Aleve. So you'll see, I'm going to try and relate it to what we as people not in healthcare may be familiar with names. However, in nursing school and NCLEX world, you're going to need to know the generic name. Again, it's going to come over time through exposure. I'm trying to relate to you of what you may already have common knowledge of, Tylenol but not acetaminophen, Motrin but not ibuprofen type thing. So that's why I'm giving you all these names right here. You don't have to know the differences or memorize all of the multiple names of drugs at this time. Just try to relate what you already know. So ibuprofen, naproxen, aspirin, ketorolac, and meloxicam, those are all anti-inflammatories. And then also celecoxib, which you'll get more in neuro and musculoskeletal as well. So the expectations of NSAIDs are going to either decrease platelet aggregation and kidney damage. So that is with the aspirin because it's a platelet aggregate, anti-aggregate. And then the decreased inflammation, fever, and pain are why we use ibuprofen, naproxen, and things like that. We're going to use this to suppress the inflammatory response, either due to an immune response or injury or autoimmune disease. Analgesia for mild to moderate pain. So this is usually our first go-to for mild moderate pain. You'll know the difference between mild, moderate, and severe pain in your foundations course related to the pain scale. So we usually use a pain scale of 0 to 10, 0 being no pain, 10 being the worst pain imaginable. And so 10, of course, would be severe, and then mild and moderate are going to be on the lower to mid side. So you'll need to relate pain scale to pain to know what type of pain medication would be appropriate for the situation. So that's where we get into the application of this. We also use these medications for fever reduction. So if someone has a fever, which in foundations you'll learn is 100.4 Fahrenheit or higher, that is considered a fever. And so if an individual has a fever, we can give one of these medications to reduce their fever. Dysmenorrhea, which is painful menstruation, it's another type of pain. So of course we can use it for pain relief. And then inhibit platelet aggregation, which is the expectation of aspirin. So we're going to use it for that reason. So aspirin is used to prevent ischemic stroke and myocardial infarction. So myocardial infarction is an MI, otherwise known as a heart attack. Acetaminophen, expectation is to slow the prostaglandins in the central nervous system, and we use it for analgesic effects such as relief of pain, as well as antipyretic effects, reduction of fever. But remember, acetaminophen does not reduce inflammation. So complications of NSAIDs, this is going to be part 1 slide. Here's where we get into those major concepts that I was talking about in orientation. So relating the concept to the classification. NSAIDs in general are going to cause GI discomfort and nephrotoxic effects. So with GI discomfort, the nurse, you as the nurse, can encourage the client to take ibuprofen with food or 8 ounces of water or milk. Dyspepsia, which is reflux, increase in acid in the stomach. And then you have abdominal pain, heartburn, nausea, ulcer formation, things like that are your symptoms. And assessment criteria that you're going to find for GI discomfort. So again, we can recommend that the client take prophylactic agents. So these are medications that you take to prevent something. So an example of these would be proton pump inhibitors like omeprazole and H2 antagonist ranitidine to decrease the risk of GI discomfort. We'll get into more of these specific medications in GI in Module 3. Just know that these are to help the stomach, and so if your stomach is hurting, when you take these medications, you can take the medication with another medication to help your stomach not hurt. Also with the GI, NSAIDs, so not Tylenol or acetaminophen, NSAIDs can cause GI bleeding. So this is the hematological effect of an NSAID, and can cause perforation due to gastric mucosal damage. So we're going to see this assessment as black or dark colored stools. Another terminology there is TARI that you'll learn in foundations, TARI stools. They're going to have severe abdominal pain, nausea, and vomiting. Of course, we're going to tell them to avoid alcohol. This is going to be in any instance of any pain medication, and we'll go into more detail about the effects of the alcohol with these medications more specifically when we talk about acetaminophen next. Nephrotoxic effects of NSAIDs. So this is the kidney dysfunction. So the kidneys are not working properly. We're going to see this on assessment through a decreased urine output, so they're not urinating like they should. They could have weight gain due to fluid retention, which we'll talk about how you can assess that in lab number 2. And then increased in BUN levels, which is the lab that we associate with kidney function. So if it's increased, your kidney is not filtering as well as it should be, and as well as an increase in creatinine level, again associated with kidney dysfunction. So we're going to use these medications cautiously in clients with heart failure, because as you'll learn in Foundations and in Health and Illness 1, heart failure clients tend to retain fluid. We'll get into the reasons why later, but for this purpose, understand that heart failure clients retain fluid, and if they're retaining fluid, one of the nephrotoxic effects we're going to see is fluid retention. So if they're having fluid retention on top of fluid retention, of course that doesn't sound fun for the patient. They're not going to be able to breathe. All that fluid is going to be backed up on their lungs. So this is going to be especially important for these clients to monitor for these nephrotoxic effects very, very closely. And how we're going to do that is monitoring their intake and output throughout therapy. So however long they're taking NSAIDs for, or go into details of how you're calculating intake and output in lab 2 again. And then monitoring kidney function during their therapy. So again, that BUN and creatinine level comes into play there. Other complications of NSAIDs include myocardial infarction, so heart attack, and a CVA, which is cerebral vascular accident, otherwise known as a stroke. So heart attack and stroke can be a complication of NSAIDs, even though, like aspirin is taken to decrease the risk, the rest of the NSAIDs actually have an increase. So for the classification of NSAIDs, technically, the classification of NSAIDs have an increased risk for heart attack and stroke with the use of non-aspirin NSAIDs. Of course, the platelet aggregate helps decrease this risk, which in this case means aspirin. So clients with cardiovascular disease should only take the minimum dose required for therapy because they already have cardiovascular disease. That means they're already at risk for heart attack and stroke, and we don't want to increase a risk. So then you got double risk, and we're likely to bombard their system and they have a heart attack or stroke because they've taken too much ibuprofen or Toradol, which is ketorolac. So we need to be very cautious in these clients. NSAIDs also have the complication of sacitalism. This is specifically associated with the use of aspirin, so it's abbreviated here as ASA. You're going to see that as a common abbreviation for aspirin. So you're going to see this on assessment as tendinitis, so ringing in the ears, sweating, headache, dizziness, and respiratory alkalosis. We'll get into more of what that means in summer semester. But just know that if any of these symptoms start to occur, that the client needs to immediately stop taking these medications, specifically aspirin, or medications that include aspirin. Now, the other one associated specifically with aspirin is Reye syndrome, or Rye syndrome. Some people pronounce it that way. This is rare, but is a very serious complication associated with the use of aspirin in children, used to treat a viral illness. So we'll see this in like children that are going through a viral illness like chickenpox or flu or common cold, and they have a fever, they're not feeling well, so then they're given aspirin. It's a fever reducer, so it does the job. However, it's actually very toxic to the child's liver and causes this Reye syndrome effect. So we do not give aspirin anymore to children or adolescents. So this is the other thing that common terminology is a baby aspirin. Just take a baby aspirin. Well, baby aspirin is not made for babies. Baby aspirin refers to the dosage. So you see on this aspirin bottle, Bayer's aspirin, it says low dose. That's what it means by baby. So the low dose, the baby aspirin, is an 81 milligram as opposed to a 325, or there's also a middle range one in there that I'm drawing a blank on. But the 81 milligrams is the low dose aspirin. This is usually the one used for preventative measures to prevent risk of heart disease and cardiovascular accidents. But this does not mean it's good for kids. Again, aspirin is not good for kids. Just don't do it. All right, I believe this is the last step of the complications for NSAID. So we have aspirin toxicity, again, associated with aspirin. So this is sacilicism, but it progresses and worsens. So if it's not caught early, this is the complication of the complication. So again, you have sweating and high fever, acidosis, which is going to lead to the dehydration, electrolyte imbalances, coma, and respiratory depression. So respiratory depression meaning low, so the patient is not breathing enough. So what happens when you don't breathe enough? You're likely to die. So this is a medical emergency. Star, 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 star. Take note of my stars. So in this medical emergency, we're going to administer activated charcoal to decrease the GI absorption of aspirin in the GI tract. So the way this works is that the aspirin that has yet to be absorbed and metabolized by the body is then blocked from being absorbed and metabolized. And then it passes through the gut because this activated charcoal blocks all of those receptors and spits it out the other end. We're also going to administer bicarbonate to reverse the acidosis and promote excretion. Hemodialysis may be indicated. If this is so severe that organs start to fail, especially kidneys are usually the first to fail, then we may need to put them on dialysis to filter out this more directly and rapidly. We may also need to provide them with a cool temperature by putting them in a tepid bath or ice packs, because again, they have a very high fever. It's spiked and may not, usually not, responding very well to aspirin. I mean, not aspirin, this is because of aspirin. It's not responding well to ibuprofen or acetaminophen. So we may need to physically cool their temperature with a tepid bath. And then we're also going to need to correct their dehydration, of course, so give them some IV fluids and electrolyte imbalances through their IV as well. Now, acetaminophen complications. So these are type of non-opioid medication, but different from NSAIDs, remember. So specifically, acetaminophen can cause acute toxicity, and this is going to be seen through liver damage. So early signs of liver damage are going to be nausea, vomiting, diarrhea, sweating, and abdominal pain. Kind of just sounds like a GI discomfort there, right? But this is where our assessment skills and criteria are going to help us recognize that this is a red flag, not just, oh, they're having GI discomfort, give them some water when they take it next time, or some milk or food. When it progresses to late signs of liver damage, we're going to see hepatic failure, so that's the liver not working, coma, and death. So, education to our clients, as well as through administration of the medications, we are going to not exceed 4 grams in a day. So 4 grams, as in 4,000 milligrams in a day. So we'll see problems like this in lab when we calculate some dosage calculations, because if they're getting this acetaminophen, Tylenol, they're getting it 3 times a day, you need to add up all 3 doses because it's a full day. So you need to be mindful of how often they're getting it. And this can be particularly important to calculate when a medication is PRN. So in the Intro to Pharmacology lecture, I talked about frequencies written on prescriptions. So PRN meaning as needed. So they may be getting it 4 or 6 times a day. So you need to figure out how often they're getting that medication and make sure that even though the order allows you to give it every 4 hours, they may be maxed out at 6 p.m. So they can no longer get any more Tylenol, any more acetaminophen due to liver damage. All right. Now, this is going to be slightly corrected for certain types of people. So clients that are malnourished, so like homeless people, downtown Macon, we're going to limit them even more to 3 grams a day because they're not going to absorb this correctly. And so it's going to be even more easily more potent. And then for those who already have some sort of liver damage, especially with alcohol abuse, alcohol use disorder is now what it's called, we're going to limit them even more to 2 grams a day because their liver is already working. And so we don't want to overwhelm that liver and cause it to give up. All right. Children dosages are going to be calculated by weight. This is the first medication we're going to see that's weight-based because this is so easily damaging to the liver. Children who are still developing, that liver is still developing, you can easily damage this liver. So there's even tighter ranges on calculating by weight for acetaminophen than there is for ibuprofen. You give a little bit of extra ibuprofen, it's not a big deal. You give a little bit of extra acetaminophen to a child, it can be a big deal. So we're going to limit over-the-counter acetaminophen concurrent, so at the same time, use with combination analgesics that contain acetaminophen. So what this means is like medications like Loratab is the street name, the brand name, but technically that medication has 2 medications in it. It is a combination analgesic. It has acetaminophen and hydrocodone in it. So hydrocodone being the opioid that we'll get into the next set of classifications in a few minutes, as well as acetaminophen. So you need to be mindful of the other medications on the client's medication administration record that may also include acetaminophen so that you're calculating your full dose, not just acetaminophen, but also combination medications for their total acetaminophen for the day. If liver damage, this acute toxicity, liver toxicity is suspected or seen, it's present, the antidote to this is going to be acetylcysteine. Star, 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 star. Acetylcysteine. This is going to be your antidote for an overdose on acetaminophen. If someone comes in and we give them a bunch of Tylenol for pain, but then come to find out, oh, they're chronic alcohol use disorder, maybe we should have not given him that much acetaminophen. We may go ahead and do this to prevent them from going into liver failure. So acetylcysteine. Alrighty, so client concerns related to this overall classification of non-opioid analgesics. For NSAIDs, our contraindications are going to be, of course, pregnancy, peptic ulcer disease, bleeding disorder, hypersensitivity, and allergy. Like we talked about with some complications, the GI discomfort, we had bleeding. So of course, if you already have GI issues and you already have bleeding issues, there's your double whammy again. So, and then pregnancy, the concern is because they are, which we'll get into in fall, your circulatory system basically doubles the fluid volume that you're putting out, which puts a strain on kidneys. And of course, like we said, NSAIDs affect kidneys. So if you're pregnant, you're going to need to monitor your ibuprofen. Now, also again, aspirin, contraindication, if you're a child or an adolescent, especially with a viral illness, contraindicated, do not give them aspirin. Ketorolac, this is like a souped up ibuprofen, usually in an IV form, can be given PO, oral, but we usually see this in the hospital setting as IV. So we don't want to give this though with a history of advanced kidney disease, because again, kidney damage with NSAIDs. Caution means that you can give it, but you still need to watch, whereas contraindication means it's more likely to cause inverse relationship with the risk versus benefit. Is going to be more risky than it might be beneficial for the client. Whereas caution, you just need to be mindful. So like older adults, history of smoking, asthma, bleeding disorders, chronic use disorder. Again, going back to your problems, if you understand your problems and your complications, then don't double whammy yourself. Ketorolac, again, because of kidney damage, we don't want to use it for a prolonged amount of time because it's like a souped up ibuprofen. That's how I explain it to patients. And it's through their IV, so it's immediately absorbed. And so it can be very toxic to the kidneys. So we don't want to be on this for too long. And this is usually a last choice for chronic pain treatment due to the increased risk of MI and stroke again. Acetaminophen, transitioning over to acetaminophen, it has this old kind of like semi-classification. Contraindications, of course, are going to be history of liver disease and alcohol use disorder. We're going to use it cautiously. Again, not a contraindication, but we're going to use it cautiously by limiting them to 2 grams a day instead of 4 grams a day, remember. Non-opioid interactions. So again, if you know your problems, your concerns, your complications, you understand your interactions. So NSAIDs, anticoagulants. So that means that it's going to stop the coagulation process, which means the medication itself is to help thin out the blood. Well, NSAIDs already have a risk of bleeding, so again, you got your double whammy. So how we're going to monitor this is our bleeding blood coags. So PTT, PT, and INR, you'll learn in foundations. Those are your coagulations, your coag labs that you're going to monitor for bleeding. We'll get a little bit more into these as well in the cardiovascular in module 2. Glucocorticoids, we'll get into, I believe, next week, is going to increase the risk of gastric bleeding. Again, like we'll see in glucocorticoids next week, have an increased risk for GI bleeding. So do NSAID, so again, double whammy. And so we can try to prevent this by taking anti-ulcer prophylactic medications. Ibuprofen decreases the antiplatelet effect of low-dose aspirin. So ibuprofen and aspirin, there's 2 NSAIDs together. So of course, double whammy. Ketorolac and other NSAIDs, 2 NSAIDs, double whammy. Over-the-counter medications. We need to educate our clients and encourage them to provide a detailed list of all over-the-counter medications, vitamins, and herbal supplements. Herbal supplements are especially going to be important when we talk about bleeding risks. So NSAIDs, bleeding, hello. So yes, it's important here. We'll get into more of it when we get into the hematology medications and cardiovascular again in module 2. Just beware again of the concept of these double whammies. Acetaminophen, we're going to have interactions with alcohol because Alcohol destroys your liver, if you didn't already know that. And so does acetaminophen, so double whammy. Warfarin slows the absorption of the medication. We're going to learn lots about warfarin in Module 2 with cardiovascular. It's going to interact with a lot of medications, especially those that also deal with the liver, but it's because the liver produces your coagulation factors. So you're going to look at bleeding at this, but it's because of the liver. I hope that makes sense. So what we're going to need to do is have close monitoring of warfarin, which we'll get into with cardiovascular later. So administering these non-opioid medications, NSAIDs, we're going to need to make sure that they are not taking aspirin 1 week prior to an elective surgery or expected childbirth. Again, due to the bleeding risk associated with aspirin. It's a platelet aggregate, antiplatelet aggregate, so it's going to encourage the thinning of blood, and if you're bleeding, you need those platelets to clot. So we're going to make them come off of this before surgery, but they need permission from the cardiovascular doctor to do so. They need to make that determination of risk versus benefit, because the reason that they're on their aspirin is to prevent heart attack and stroke. And some of you may ask, what do you mean expected childbirth? Well, what kind of childbirth would it be? Well, in your 3rd trimester, when you're near the end of your pregnancy, you have, it's a due date, but it's relative. Whereas expected childbirth more refers to you're going to be induced on this day or have a C-section on this day. It's like specific. So you can actually come off for that week. Whereas if you go into labor, you can go into labor at any time. So you don't really get a window of a week. You can guess, but you're not going to be right all the time. Whereas if you have that expected date, then you can do the entire week. That's what it's referring to. So again, with NSAIDs, with the GI discomfort, we're going to encourage them to take with food, milk, or water. Usually this is always going to be in the 8-ounce form, so just remember 8 ounces. That's not really going to change throughout the semester. Don't chew or crush enteric-coated or sustained release aspirin or any medications. You just don't crush or chew them. Any enteric-coated or sustained release, I want to clarify that. Those medications specifically have that coating on them, and taking or what is it? Damaging that coating interferes with the medication and how it's being absorbed. So it interferes with the dosage, essentially, that will actually be metabolized. So keep that in mind. So don't do that. And then, of course, notify the primary medical doctor, PMD, of any symptoms, and discontinue aspirin until all manifestations resolve, such as bleeding. With acetaminophen for administration, we're going to keep a total daily intake of all prescribed and over-the-counter use, remember, following the recommended dosage to prevent toxicity. So remember your 4 grams, 3 grams, 2 grams for your different types of clients. The US FDA recommends take only 1 product at a time, and to read labels carefully to determine amount in each dose so that you can calculate and make sure that you're staying in your recommended dose range. And remember to an acetylcysteine. So administering acetylcysteine in, sorry about that, in the event of an overdose to prevent liver damage. Which means, remember their signs and symptoms included a lot of GI discomfort, nausea, and vomiting, things like that. They might not be able to take this because it's an oral form. So we may have to put it in a nasogastric tube in order to pump this into their stomach and prevent them from emesis, which is vomiting, and aspiration. So refluxing or beginning to vomit, but then while it's in your esophagus, you inhale, and so it goes into your lungs. That's what aspiration is. So they inhaled gastric secretions. It's great. And of course, not good for your lungs. We'll get into more of that later. So then after we administer the medication, we're not done. We still have to go back and watch our client in any situation. So we're going to evaluate effectiveness of the medication and look for any complications again. So based on the purpose of the administration, so you need to know why we gave it. Did we give it because they're having inflammation, they're having pain, or did we give it for a fever? So if we gave it for a fever, then we're going to evaluate effectiveness by checking their temperature. If we gave it for pain, then we need to monitor, evaluate their effectiveness by monitoring their pain level. So it's specific to the purpose of the administration. Okay, the next classification that I'm going to go into is the opioid agonists. So these are otherwise known as opioid analgesics. So these are going to reduce pain by attaching to the receptor in the central nervous system that alters the perception of the client's response to the pain. So it's not actually getting rid of the pain, it's tricking the brain into thinking that that received message that the body is in pain is not true. So this is going to include like morphine, fentanyl, meperidine, which the brand name for that one is Demerol. And that one may be more commonly known as Demerol, but you'll need to know the generic name. Had a brain fart for a moment. Here is the meperidine. And then you have also methadone, codeine, oxycodone, and hydromorphone. Those are all the ones in this classification, the main ones that we're going to be familiar with in their nursing field. The other name for hydromorphone is Dilaudid. So Dilaudid for hydromorphone and Demerol for meperidine. The expectations of these, of course, are going to be analgesia. Depending on what type of how it attaches to what receptor in the central nervous system, the mu receptors versus the kappa receptors is going to produce those other effects. So with the ones that attach to the mu receptors, they're going to also, in addition to altering the perception of pain, therefore providing analgesia, are going to have respiratory depression, euphoria, and sedation, whereas the ones that attach to the kappa receptors are going to cause sedation and decreased GI motility. Sorry about that. So decreased GI motility means that the GI system is not working as much, therefore slowing down, leading to constipation. So we'll see that in a moment. The use of these, this class is going to be to, of course, relieve moderate to severe pain. So there's where you have your pain scale again. So this is going to be like 7 or higher, moderate to severe. So this is going to be in cases of like post-op, so after surgery, myocardial infarction, so a heart attack, as well as childbirth and cancer and other things that are extremely painful. Trauma is another one. We're also going to use this for those other effects for either sedation, reducing the bowel motility, and cough suppression, such as like with codeine. It will coat the throat and prevent some throat irritation and pain like that. Cough syrups in that sense. So complications of opioid agonists are going to include kind of what we've already started talking about with respiratory depression, constipation, orthostatic hypotension, and urinary retention. So respiratory depression is when the lungs, essentially the respiratory system, is going to be depressed, so it's going to stop working. So we're going to see this as them stop breathing. So we need to, of course, monitor their vital signs to see this. We're going to discontinue, that's what this D/C stands for in my little shorthand here. So discontinue the medication if the respiratory rate is less than 12 per minute, so 12 breaths per minute, and notify the primary care doctor. We're going to have to administer naloxone as a reversal. It's going to, that's in the next, yes, the next classification I'm going to discuss. So we'll go more into naloxone and how this reverses it, and therefore resuscitating the client and getting them to breathe again. Of course, we're going to encourage to avoid concurrent use of other central nervous system depressants, such as barbiturates, benzodiazepines, and alcohol use, as it also has this common effect of respiratory depression, and again, double whammy. So next complication is constipation. So constipation, because it's decreasing that GI motility, so slowing everything down, like I said. So we're going to encourage the client to increase their fluid and fiber intake, as well as physical activity to promote that bowel movement. We may have to administer a laxative. Sorry about that C. I'll try to fix that on your original one. Laxative or stool softener. There's differences in those. We'll get into that in the GI lecture in Module 3. Also, we can administer opioid antagonists for long-term treatment. We'll get into those types of things and this will be seen like in patients with cancer or AIDS, where they have the chronic pain, and therefore they may end up with chronic constipation as an effect of that. And sometimes we can combine an agonist and an antagonist so that it decreases these defects. Orthostatic hypotension. So ortho meaning being in the musculoskeletal domain, static meaning moving. So this means that when a person stands up or changes positions from a lying to sitting, lying to standing position, and hypotension means that their blood pressure drops. So when they move from those positions or do it suddenly, their blood pressure drops. So that's what orthostatic hypotension means. This is going to be due to a dilation effect of the peripheral vasculature. So if the blood vessels open, they dilate, then the pressure on those vessels is low. So then they're going to get lightheaded, dizzy. They may actually pass out. So this is a common effect after an opioid agonist is given. So we're going to advise our clients to change positions slowly, that they should sit or lie down if this begins to occur, and of course hit the nurse button and call the nurse. This is going to be why any patients that are on any pain relief for severe or moderate pain, such as the reason that we give these opioid agonists, will be on fall precautions due to this effect. All right, next is urinary retention. So this means that they are retaining, keeping the urine in their bladder. They do not get the urge to urinate. So this is because it suppresses the awareness that the bladder is full. Remember, the signals going to the brain is being altered. So this incidentally gets trapped in that alteration and denies that response. So they don't know that their bladder is full. So we're going to need to assess their abdomen, their lower abdomen. Ooh, that's too many typos on one slide. I'm sorry, guys. Lower abdomen. So we're going to palpate that every 4 to 6 hours. You're palpating in that lower area where the bladder is to feel for any distension or pain when you press on it. But again, their pain may be altered because they're taking pain medications. So you really have to go off of your assessment there. So we're going to ask them to also get up and go to the restroom every 4 hours, even if you don't have the urge to go, because you may not have the urge to go because of this reason. So it's not walking in the room, knock, knock, hey, Mrs. Smith, do you need to go to the restroom? All right, well, thank you. Let us know. Hit your call button, and then you walk out the room. No, this is knock, knock. Hey, Mrs. Smith, let's go up, get up and try and go to the restroom real quick. You're going to tell them it's time to go, not give them the option so that they're emptying their bladder. And then we're also going to be aware of and monitor for this effect even more so in the cases that clients that are also taking anticholinergic medications. So if these are like antihistamines or antidepressants, often have an anticholinergic effect. We'll get into that a little bit more later. But anticholinergic is essentially going to cause like a drying up and tightening of all of the fluid in blood vessel systems, and so it's going to not let them relieve themselves as frequently. So again, double whammy with urinary retention. All right, next complication is cough suppression. We may use it to cause cough suppression because they have a severe cough. However, those that are just taking opioid agonists for pain relief but just had surgery, you're going to learn about in foundation stat. We're going to need them to use an incentive spirometer, cough and deep breathe, cough at regular intervals because of their risk for pneumonia. So their lungs aren't, I wouldn't say functioning at full capacity, but they're not prompted to function at full capacity more so than anything. And so they don't have the urge to cough, even if they do have phlegm or mucus or an irritation, and therefore whatever that's there isn't being removed. That's the reason we cough, is to remove things from our lungs, right? So if we aren't coughing when we're supposed to, those things get stuck in the lungs and causes pneumonia. So we need to assess for this that may occur and encourage them to cough at regular intervals so that they may not feel the urge to cough, but they can still cough. So just reminding them to cough. So again, just like getting up to go to the restroom, remind them, all right, it's time to cough, do your incentive spirometer, open up those lungs. We're going to listen with our stethoscope, which is called auscultation. We're going to auscultate their lungs for crackles. So that's like a watery, drippy noise, so that when they're inhaling or exhaling, you'll hear this noise there. I'm going to try to have the mannequins in the lab turned on so you can hear these different lung sounds. So you can hear what crackles versus other lung sounds sound like with your stethoscope. We're also going to increase their fluid intake so that they can liquefy their secretions so that they're not dried out so much, and thinning out those secretions so that they can cough them more easily out. Another complication is sedation. Of course, with any kind of medications that cause sedation, we're going to avoid hazardous activities, so like driving or operating heavy machinery. Operating heavy machinery is the common thing that's printed on little pamphlets for medication when you pick up your meds from the pharmacy and things like that. But people don't realize, I mean, we might realize, but we're in the healthcare facility, in the healthcare realm, but laypersons may not realize operating heavy machinery isn't just like tractors and forklifts. It's your sevehicle, your car, your truck. That also means that. So until you know how this really affects you, how sedative it affects you, you really shouldn't be driving your vehicle, regardless of how it affects you. But the fact being on these medications, you should definitely be aware of an increased risk for injury as a result. Nausea and vomiting is going to be common with opioids as well. So we're going to administer an antiemetic. So those are medications to anti-emesis medic. So emesis being vomiting. So to stop the vomiting. Biliary colic can happen with morphine. So we may have to use meperidine, which is Demerol, as an alternative. So those that already have biliary concerns or history of biliary stuff. We'll get more into that next semester when we talk about surgeries. Opioid overdose triad. So this is drug overdose. People talk about opioid overdose. So this is when we get the coma, respiratory depression, and pinpoint pupils. So all three of those are together, meaning the triad 3. So we're going to need to monitor their vital signs, provide mechanical ventilation as necessary. Mechanical ventilation here is referring to bag mask or a ventilator. So we are mechanically ventilating their lungs. We are pushing and pulling the air in and out of their lungs to oxygenate their body because they are no longer breathing on their own. Or supporting their breathing if they are breathing on their own. So in these cases, we're going to administer, again, naloxone to reverse these effects, which is an opioid antagonist. So concerns and interactions. Contraindications, like I said, morphine after biliary surgery. Meperidine for kidney disease. We're going to use cautiously anyone who has lung disorders because, again, remember, respiratory depression. So asthma, emphysema. If they have any problems with their central nervous system, so if they've had a head injury, things like that. So we don't want to, again, double whammy. Inflammatory bowel disease already has those issues of the bowel motility concerns. Then you have the history of enlarged prostate because of the urinary retention. So think of your complications again and what's going on with these disease processes. So you're going to use cautiously so that you avoid the double whammy, right? Interactions are going to be other central nervous system depressants like I talked about, so because of the additive effect, so the double whammy. So we're going to need to warn or educate our clients about that. And alcohol is another CNS depressant that they need to be aware of, so not just medications. Anticholinergics, antihistamines, and tricyclic antidepressants, which we'll get into in neuro, also have the additive effect, so increasing the fluid and dietary fiber to prevent constipation and urinary retention. We also have antihypertensives can have an additive effect to the hypotensive issue, that orthostatic hypotension, so avoid a concurrent use of POM. I'm sorry, I forwarded to the next slide without finishing. I'm going to just go over the MOIs and the increase in analgesia, last 2 points that I missed on the last slide first. So medications like MOAIs and meperidine can produce a hyperpyrexic coma. Hyperpyrexia is an increase in temperature, pyrex, and so it's a fever-induced coma. This is going to be more true with MOAIs than anything else. We're going to see those later, but MAOIs don't really mix well with other drugs. They don't like friends, so just be cautious at any time giving an MOAI later. So we'll go more into that later, but that's going to look like First, excitation. That excitation, hyperreflexia becomes seizures, and then respiratory depression. So, of course, we're going to avoid concurrent use of these. And then amphetamines, clonidine and dextromorphin, those used in conjunction with an opioid agonist can actually increase the analgesia effect. So our education here is going to avoid medications with other concurrent use with opioids that also have CNS effects. So when we're administering opioid agonist, first we're going to assess and document their pain regularly, if we're giving it for pain, at least in that sense. So we're going to need to know the patient's pain level before, during, and after we give a medication. So assessment is going to be ongoing and throughout administration. So we need to know the pain scale before we give a medication. If we, especially, and then immediately during or after, depending on the route, which is going to determine the onset of the medication effectiveness. And then we're going to continuously monitor them for any complications or side effects. And then we're going to follow up again after the peak time of the medication to assess effectiveness, that it was effective or not to relieve their pain. We're also going to obtain baseline vital signs. That's what this VS means, vital signs. So we need a set of vital signs before we give this medication. Even though they tell us their pain is so severe, it's like a 20 out of 10, I still need a set of vital signs before I can give you this medication. Because what if they're actually not breathing as well as they should be? So we need to know what that respiratory rate is above all else. All the other vital signs, of course, are going to be very important. Of course, they may be affected due to their level of pain. But if their respiratory rate is already less than 12, they're already risking respiratory depression before we add an opioid agonist like morphine. And it's going to have that compounding effect and more likely to lead to respiratory depression, death, coma situation. So definitely before we administer, if they have a low respiratory rate, we need to let the doctor know and be like, are you sure you want this medication? This is what's going on with the patient. And then if they still say, use your nursing judgment. You're going to follow procedures for controlled substances, because these are controlled substances. You're going to double check your doses with a second nurse prior to administration. This is going to be true with all controlled substances. If it's an IV form, we're going to administer it. We're going to push it slowly. So it's going to take about 4 to 5 minutes to push this medication. And you need to have naloxone and resuscitation equipment available or nearby. So don't be giving no morphine to a patient, first off, without having vital signs. But second off, without knowing if you have naloxone available or know where the crash cart is, because these things happen. Of course, we're not going to ever increase their dose without consulting the doctor. Don't increase the dose. That's changing the order, and you don't have that in your license, in your scope of practice. Cancer clients are going to be on a fixed schedule around the clock, so they're not going to be like as needed for pain because they're in chronic pain. So they're going to be getting these on the clock, around the clock, every 4 or 6 hours or whatever. And they may even have supplemental doses as needed. For clients that are have opioid dependence, we can't just stop them. So if someone comes and they're taking street drugs, they come to the hospital and no longer have their street drugs, what do you think is going to happen? They're going to go into withdrawal. Same thing here. If they're taking oxycodone at home, prescribed or not prescribed, so I guess this could be street drugs too. You can't just stop them, so you have to taper them off of the medication over 3 days to withdraw them slowly.
to hopefully prevent them from going into withdrawals. But if they do, it's not going to be as severe if you cut them off cold turkey. Cold turkey actually kills more people than the general populace thinks. Even alcohol. Can't quit alcohol, quit turkey if your body's used to it. You can kill them by doing that. So we'll talk about that later with banana bags and stuff. Anyways, off my high horse. PCA pump. This is patient-controlled analgesia. So this is an IV infusion that's going continuously to their IV, and they are getting the medication not only continuously, but they have this little handy-dandy button. So if they're in pain, they can give them, push the button, and the pump will then be triggered to give them an extra dose of the medication. However, they're only going to be able to get that extra dose of the medication so frequently. So you need to make sure that the pump is set up for the correct dose. It's got the right lockout interval and limitations. So they can press the button all they want, but that doesn't mean they're going to constantly get push a fentanyl, because then they can overdose. So these safeguards are in place for a reason. A lot of pumps, at least in this area, have guardrails. So it will let you know when you set the pump that this is outside of the guardrail limits. Are you sure you want to proceed with this high dose or this short interval? Things like that. So also with pain medication in general, not just with PCA pumps, but we need to encourage like a prophylactic use of the pain medication prior to activity. So if a patient has like physical therapy scheduled in like 30 minutes to an hour, we can encourage them that, you know, they could go ahead and press their pump button, or I can go bring them, you know, their oxycodone tablet, something so that they aren't in pain later. It's not really for their pain now. They may not be in pain now, but they're going to be later when they're done with physical therapy or during physical therapy. So be mindful of those things. Also be mindful of like how they tolerate it. So don't give them like a push of Demerol right before physical therapy, because orthostatic hypotension, they're not going to be able to tolerate, and they're going to be dizzy, things like that. So you need to be mindful of that, of a good window. So like the peak isn't right during, but like when is their pain going to occur is the main thing. Then you need to time it accordingly. Also, so this next line, adequate dose to cover until PO. So this means that if they're on this pump and they're getting this continuous infusion, but the doctor orders for it to be discontinued and switch to PO tablet of hydrocodone. If that's the case, then okay, great. Maybe their pain's getting better. We're going to see at least if they can tolerate on a hydrocodone instead of a continuous infusion. So we're trying to transition them to a PO dose. That's great, but don't discontinue the infusion until after you've given the medication and you've had enough time for the peak for it to have its onset. Remember, PO drugs take at least 30 minutes to start being in effect. So don't stop the infusion, which is going to stop giving them pain relief within the next few minutes. But then their pain relief from the pill you just gave them doesn't cover their pain for another 30 minutes. So you're making your patient be in pain for 30 minutes. So just be mindful about those and make sure that you're covering them until the PO is able to take an effect. Transdermal fentanyl patches. So you're going to administer these with short-acting opioids. This means that if a patient has a fentanyl patch on, it's similar like a pump, an infusion. So this is continually giving them a dose of fentanyl transdermally throughout the day or several days depending on the patch. So in that case, their baseline is being covered. And so when we're giving them additional pain medications like supplemental dosing, we need to make sure that they're short acting, or at least if you don't give a short acting opioid, that you're monitoring them very frequently, because you don't want a long acting opioid on top of this other long acting opioid with a compounding effect and they stop breathing. Not immediately after you give it, or even at the peak, but towards the end, when it's at its highest effect right after the peak. It has time for the body to metabolize both long-term medications, and it's just a lot on the body. So just be mindful of long-acting medications compounding as well. Opioid agonist evaluation effectiveness. So why did you give it? Was it for pain? Then go reassess their pain. Was it for cough suppression? Are they still coughing? Was it to stop them from having diarrhea? Go see if they've stopped having diarrhea. So what was the reason for it? Then you need to reassess it and then evaluate, was the medication effective? Then great. If it wasn't effective, then what can we now do to help or supplement? So you need to let the doctor know if you don't have any orders or parameters for those things. But if it also monitoring for any side effects or complications. Okay, the next classification is going to be opioid antagonists. So this is going to attach to the receptor site and prevent the response. So it's going to attach to the receptor that agonists usually enter the cell through, so that an agonist cannot enter the cell. So this is preventing an opioid agonist from taking effect. Examples are going to be naloxone, naltrexone, methylnaltrexone, and alvamopan. Most common one you're going to see is the naloxone, otherwise known as Narcan, which is the brand name. We expect this to interfere with the action of opioids by competing for the opioid receptor. There's no effect in the absence of opioids. So giving an opioid antagonist to attach to the site doesn't really matter, because it's used to prevent an opioid. So if there's not an opioid in the system, there's not going to be an effect to the patient. We're going to use this to treat opioid abuse by preventing euphoria. We're also mainly emergently going to use this as a reversal of opioid effects such as respiratory depression. So you give the medication, an opioid agonist like morphine, Dilaudid, or hydromorphone, and the patient starts to not breathe well, gurgling, respirations, intermittent, not regular. You're going to react by giving them naloxone. So this is going to reverse the opioid effects, because it's going to attach to the site so that the opioid agonist stops working. So essentially we're using this to reverse severe opioid cause respiratory depression. So we're also, the other reason for opioid agonists, it's going to be opioid cause constipation, with long-term treatments of opioids, like with cancer and other chronic pain disorders. Opioid antagonist complications are going to include tachycardia, tachypnea. So we're going to need to monitor their heart rate and rhythm and respiratory function, of course, and have a resuscitative equipment on standby during administration of naloxone, which includes oxygen. Abstinence syndrome is another complication. So if they are used to getting their opioid agonist and you give them an opioid antagonist, it's like a withdrawal, because they're not getting what their body now needs. So cramping, high blood pressure, vomiting, and reversal of the analgesic effect. And so this, of course, like I said, is going to occur when given to clients who are dependent on those opioid agonists. So contraindications of these medications are going to be pregnancy, opioid dependency, because we don't want to then cause withdrawal right now. History of hepatitis or liver failure. I'm sorry, there's another typo. And lactation. We're going to, of course, caution again now in pregnancy. Opioid antagonist administration. Do not ever mix naloxone PO. Don't administer naloxone as a PO. Why are you giving naloxone? Remember, it's to reverse an opioid. How long does an opioid take? So it just doesn't make sense because it's going to take too long and you're giving it for a reason. You need to correct that reason now. So IV, IM, or sub-Q. The PO effect has that first pass inactivation as well. So it's not really going to be as effective once it even begins to start to work. Observed for withdrawal signs and symptoms or abrupt onset of pain. They took the opioid. Now their pain was relieved. Maybe they took a little too much. Having respiratory depression. Now we give them naloxone, the antagonist, and it competes for those sites, so the opioid agonist is no longer working. So they're in pain again. But if their body is used to the opioid agonist and you prevent it from receiving an opioid agonist, you're going to cause withdrawal. You may need additional analgesia if used for reversal of respiratory depression. So this is immediate. So emergency room, someone's come in with an overdose and we give them naloxone. Like, you push it, you flush it, and they're like jumping up from the bed, pissed off, or they're vomiting on your shoes. This is immediate. So if it doesn't occur immediate, either you didn't give enough because of how much they overdosed, so maybe you need another dose or 3. But once you realize it's not taking effect, it's because it's not an opioid. So what did they take and what is going on? So it's usually our first go-to just because it is so immediate, and then we know within a few minutes if it's opioid or not that's causing their reaction. We're going to titrate their naloxone dosage to achieve reversal of respiratory depression without reversal of analgesia. So this is giving it along with an opioid agonist. So we may need to increase or decrease their antagonist to get the desired effect of still providing analgesia without causing respiratory depression. So we're going to administer naloxone when we give it slowly, due to the risk of high blood pressure, tachycardia, nausea, and vomiting. So just think of withdrawal symptoms and how they're first seen before you get into like the seizures and everything else. But your first symptoms of withdrawals. Subsequent dosing of naloxone may be required due to the half-life of opioid analgesia being longer than the 60 to 90 minutes. So naloxone is usually only going to last for that short period of time. But if your opioid is a longer acting than your naloxone is, the opioid is going to take back effect. So just because now they're awake or they vomited and they seem fine, you don't just walk out of the room and be like, I'll just wait for them to keep sobering up. No, because you need to keep monitoring them. If that naloxone kicks off and there's still that opioid on board, they're going to return right back to that state that they were in. So you need to keep monitoring them, especially the respiratory rate for 2 hours after the administration to see if they return to respiratory depression. Okay. Opioid antagonist evaluation of effectiveness. Usually it's given because there's respiratory depression going on. So did we reverse their respiratory depression, and how do we assess that? So their respiratory rate is regular. What is regular? 16 to 20 breaths per minute in adults and 40 to 60 minutes in the newborns, or otherwise absence of shortness of breath symptoms as well. Now, Naltrexone is usually given to reduce the euphoria and alcohol dependency and decrease the craving for alcohol. So we'll see these in alcohol abuse patients in the hospital. And Alvamilpan and methylnaltrexone it's for severe opioid-caused constipation. So is there constipation relieved? Opioid agonist, antagonist. So these are those combination medications all in one. This is going to bind to the receptor to cause a response and to another receptor to prevent the response. So remember that mu and the kappa receptors, one for the opioid agonist would produce like euphoria symptoms, and the kappa would produce the other. So, or the mu is the respiratory and the kappa is the euphoria. So it's going to bind to both of them so that it allows one but does not allow the other. So nalbuphine is going to be the most common one there. Nalbuphine. So again, the expectation is an antagonist to the mu, so you don't cause respiratory depression, an agonist to kappa receptor, so you still get some analgesia. Buprenorphine is the opposite, it's backwards. Lower potential for abuse, of course, due to not causing much euphoria and respiratory depression and analgesic effects. High doses, though, can cause anxiety, restlessness, and mental confusion. So be mindful of that. We're going to use this to relieve moderate to severe pain, of course, treatment of opioid anesthesia and relief of labor pain. So again, these are used for pain. So think of like high doses of pain medication, but we want to prevent the complications of it at the same time. Combination. So complications are going to be abstinence syndrome. So again, the cramping, high blood pressure, hypertension, vomiting, fever, and anxiety occurs in clients who are dependent on opioid agonists. They need to stop taking the opioid agonist before using agonist-antagonist combinations. So we need to avoid if opioid abuse is suspected or opioid use is going on. Sedation, respiratory depression, again, have naloxone and resuscitative equipment available, and monitor for respiratory depression signs and symptoms. Dizziness, caution standing up quickly, avoid driving or using heavy machinery. We've heard this before with opioid agonists. Headache, signs and symptoms of headache, need to assess for, ask for, and assessing their level of consciousness as a result. Concerns and interactions. Contraindications are going to be, of course, if they're dependent on opioids or they're already in respiratory depression. Caution with those with MI, kidney or liver disease, and head injury. Interactions are going to be CNS depressants and alcohol because of the additive effects compounded. Opioid agonists, again, opioid agonists and antagonists and reduce analgesic effects. So don't add them together. Administration, you're going to make sure that you have baseline vital signs before you give it and that the respiratory rate is less than 12 and hold it if it's not, and notify the doctor. Have naloxone or resuscitative equipment available. Assess for opioid dependence prior to administration, as these can trigger withdrawal symptoms. These medications can. Don't increase the dose without consulting the doctor, of course. Changing position slowly. Don't drive or operate heavy machinery. These are just like opioid agonists. So think of them similarly. Evaluation, did they improve on the reason that we're giving them? So is their pain better? Adjuvant medications for pain. We're using these for primary pain medication to increase pain relief while decreasing the dosage of opioid agonists. It can be an off-labeled use.
as well. The expectation is going to reduce adverse reactions such as respiratory depression, sedation, and constipation as what's present in opioid agonists. So categories are going to include tricyclic antidepressants, anticonvulsants, CNS stimulants, antihistamines, glucocorticoids, bisphosphonates, and NSAIDs. So the adjuvant medications are given in addition to a pain relieving medication. So they're going to be used for the purpose of a compounding effect. And we'll get in more into those specific classifications later. But just know that you can add medications to a pain medication to have more pain relief, but the other medication is not another opioid. All right, so next classification are going to be this, what your book calls miscellaneous pain medications. So this first part is going to be migraine medications. The expectation of migraine medications is to prevent the inflammation and dilation of the intracranial blood vessels, thereby relieving the migraine. We're going to use this to stop a migraine after it begins or after prodromal manifestations start. These types of medications are called abortive. So it's already in the process, the migraine, and then the patient takes the medication and then stops it from progressing. So these are like NSAIDs, combination anti-inflammatories, triptans, and ergoalkaloids. The other type of use is prophylactic therapy to prevent a migraine. So the migraine hasn't started, but the patient gets frequent migraines, so they're on a prophylactic medication once a week, every day, type of things to prevent migraine from occurring. So examples of these are going to be like beta blockers, anticonvulsants, amitriptyline, and estrogens. Of course, with aspirin-like drugs, you got the aspirin complications. The serotonin receptor antagonists, we'll get into more when we get into cardiac. So just remember cardiac here for cardiac symptoms. So you're going to watch your vital signs. Beta blockers, again, we'll get into more when we get into cardiac, but they slow everything down. So think of everything slowing. So they're going to get tired and fatigued. Bradycardia and hypertension, of course, so then we're going to monitor their vital signs. Ergoalkaloids, think GI, and neurovascular, but we'll get into more of that again with later. Anticonvulsants, convulsant meaning convulsing, I don't know. But so this is a seizure essentially. So GI distress, neural tube defects can occur with anticonvulsants. Hepatitis, so monitoring their liver, and pancreatitis, and so watching for that abdominal pain. Tricyclic antidepressants are going to have this anticholinergic effect. So remember, I mentioned before, anticholinergic is just think of drying. So everything gets dried. So your mouth is dry, your bowels are dry, your bladder is dry, your eyes are dry, and your heart is dry. So what happens? Drowsiness or dizziness. So of course, operating machinery as well. MAOIs and SSRIs, those just don't like to play well with others. Specifically, I want you to remember SSRIs due to serotonin syndrome. We'll get into more of this later, but just start thinking about this concept about confusion, agitation, hyperthermia, so increase in temperature, body temperature, diaphoresis, so they're sweating, and then death. Beta blockers, remember, they're slowing everything down, so given with diuretics, so they're peeing everything out, decreasing their blood volume, and antihypertensive to bring their blood pressure down. of course, they're going to also affect blood pressure. So blood pressure makes it blood pressure. You're going to drop their blood pressure. So monitor their blood pressure. Specifically, you need to look at this range of a systolic less than 90. You're not going to give anything to a patient that's going to affect their blood pressure if their systolic number is less than 90. You'll get into with foundations systolic versus diastolic. So systolic is your top number of your blood pressure, and your diastolic, D for down, is the bottom number of your blood pressure. That's essentially the main parts of the slide I want you to know. Administration. So the abortive medications, so the medications that are used to stop a migraine that's already in progress. If they are having to stop a migraine more than 2 times a week, they need to no longer be on an abortive medication. They need to look at other treatments and probably a prophylactic, because it ain't working. So don't use an abortive med more than 2 days a week. These are usually very high dosed compounded medications, and getting that high dose frequently, it's not good for the body. So they need to be aware and let their physicians know. And of course, avoiding triggers what causes their migraine. Stay away from it. Ease their symptoms by lying down in a dark, quiet space, limiting that stimuli. Antiemetics in combination, adjunct to add to these pain medications, because often migraines come along with nausea, right? Check their apical pulse before giving a beta blocker, because remember, beta blockers are going to slow everything down. Take with food to decrease their distress in their intestines and increase the absorption of the medication. Protect their eyes from the sun, avoid driving operating machinery, and then caution in cases of orthostatic hypotension occurs. Because again, these are still pain medications. And then we're going to evaluate it. So why did we give it? So then we need to determine if their migraine has stopped, if it was an abortive one, if they haven't had a migraine in like 6 months, then their prophylactic one is probably working. And then reduction in size or frequency of medication doses. So if last year they were on 30 milligrams, but this year they're on 50 milligrams, then it means that it's being therapeutic. It's working for them. They don't need as much to have the same effect now. All right, the second part of these miscellaneous medications I quoted, but you can't see my quotes, are going to be the local anesthetics. So like lidocaine, tetracaine, procaine, and Imla cream. So this is an abbreviation, so that it's got lidocaine, and it's a mixture of things. It's cream. It's got lidocaine in it. You put it on the skin. Can't think of what the acronym stands for. So your expectation for giving a local anesthetic is to decrease the pain impulses in that specific localized area. Parenterally, we can give it for pain management for various procedures like labor and delivery or regional anesthesia. Topically, we can give it for skin mucous membrane disorders, control laryngeal esophageal reflexes prior to endoscopic procedures before they put the tube down the throat so that the larynx doesn't spasm, or minor procedures like IV insertions, injections, and wet room birth. Straining my voice there. So this is like the Imla cream. So we're going to put the cream on the area that we plan to do the IV in, especially like with pediatrics. Cover it up real nice and good so that doesn't spread, because we want it in the localized area, not become a systemic, as well as to increase the absorption effect of the medication. So then we come back in a few minutes and the area is nice and might be a little cold, cooler. It might be a little paler, but that means it's working. So it is numbed, and then you can do your procedure, and not painful. Complications. CNS excitation. So it's going to rumble up the CNS system, exciting it. So that excitingness, it turns into seizures, which can turn into respiratory depression and being unconscious. We then, of course, need to monitor for seizures, for sedation and change in mental status, like a decreased level of consciousness. If this occurs, we need to administer a benzodiazepine to treat seizures. We'll get into more of this later in the neuro section and anticonvulsants specifically, but if a seizure occurs as a complication, you need to know this now. So a benzodiazepine is going to help calm, it's a CNS calmer, I guess. So it's going to calm down that excitation, slow down the seizure, hopefully stop the seizure. And so examples of those are like midazolam or diazepam. Hypotension and cardiac suppression is going to be seen as bradycardia, heart block, cardiac arrest. So of course we're going to need to monitor their vital signs and their ECG or EKG. They're the same. Allergic reaction. This is more likely with the procaine and ester types, which isn't really common anymore. So we're going to use the amide types for injections. That's just a little bit of my nerdiness that I wanted to include in this because I had to learn the difference of this when I worked in interventional radiology. But generically, I don't think you're really going to need to know those. Observe for allergic dermatitis or anaphylaxis, of course. So if we're giving it to the local skinny area, we're going to look at the skinny area to make sure it doesn't get infected or have a reaction to it. We're going to treat with antihistamines or by the agency's protocol to treat the allergic reaction. Antihistamine example would be like Benadryl. So the generic name for Benadryl is diphenhydramine. Spinal headache, I think is the only real other thing that I want you to know on this slide, is if, like, let me get my thoughts. Woman is going in to get an epidural because she's about to have her baby. Epidural is going to be pain relief injected, not necessarily locally, but injected into the spinal area so that it causes the analgesic effect to the nerves that's going down to their legs, right? So it's still kind of locally, it's not systemically, but accessing that spinal space can leak out spinal fluid, causing a spinal headache. So this isn't just a regular headache. This is a very, very severe headache. Photophobia, nausea, vomiting, unrelieved with Tylenol or even opioids, because it's like migraine, but you can't relieve it by migraine ways because it's not due to inflammation or dilation of the blood vessels. So this needs to be fixed with that leak that is happening. So we need to make sure that they lie flat in the bed for 12 hours post their procedure. So this is going to help make sure that that spot closes up nicely, forms that little scab so they're not wiggling around in the bed to prevent that leakage, to prevent that severe spinal headache. Only in those cases of like epidurals. Any dysrhythmias that the patient may have is going to be contraindication because this can cause dysrhythmias and cardiac suppression, right? So if they're already not doing great, don't give them a lidocaine. especially lidocaines that are mixed with epinephrine, which we'll get into later. Epinephrine also, when it's mixed, called concurrent, the anesthetic that has epinephrine cannot be injected into the fingers, toes, nose, and extremities. Okay, let's say it again. Epi, lidocaine, cannot go into the fingers, toes, nose, and extremities because that's the end of the blood vessel. The epinephrine is going to cause vasoconstriction. If you cause vasoconstriction to your extremities are no longer going to be perfused. So what's going to happen? That limb is going to fall off. So like the tip of your nose, the edge of your ears, your lips, your fingertips, your toes, things like that. Anything that's on the outer edge, need to be mindful of those things. So like a patient comes in, they have a laceration to their ear. Well, do not pull lido with epi. Pull regular lidocaine for your patient, for the doctor to do the seizures. Also need to be mindful of self-inflicted injuries as a result of the numbed area because you can't feel it. So if the numbed area is on their foot, they can't feel when they're walking, they're going to stub their toe and not know it. They got a big old gash on their foot and it's going to be infected. So think of those things. And then the additive hypotensive effects when you give other antihypertensive, like I talked about before. So monitoring their heart rate and blood pressure. Don't give anything that's going to add to the double whammy, remember? All right, administration. Remember to avoid hazardous activities during recovery due to that numbed area. Make sure that they're in a position for comfort because before you do this, because once they're numb, they're not going to be able to know they're not comfortable, but until it wears off, and they've got severe back pain because they were laying weird. For local anesthetics, vasoconstrictors in combination, so if it's got epinephrine, is helpful to prevent the spread of the medication so that it is still a local effect. It also prolongs the anesthesia and decreases the risk of the systemic toxicity. But again, make sure that you don't do it to extremities. So cleanse the area, shave it if needed, model vital signs and level of consciousness, maintain an IV access for emergency and resuscitation equipment as needed, and protect the site from injury during the recovery period. Monitor for hypotension, anaphylaxis seizures, and dura punctures, respiratory depression or sedation, sites for hematoma or signs of infection, and the level of the block. So where was it when you get the spinal epidural injection? Prepare IV fluids to reduce the effects of sympathetic nerve blocks. Make sure that they lie supine for that 12-hour post-op period to prevent that spinal headache. Notify provider if they haven't voided in 8 hours. You should do that. And then EMLA, the topical version, apply the small amount to intact skin about an hour prior to the procedure. This can also be done at home prior to the procedure so they can get a prescription and pick it up if they're going to have a procedure that they know they're going to have to do later. They can go ahead and put the EMLA cream on the baby's arm or foot just to get that area nice and numb, and then they can walk into the hospital and not have to delay their care for that hour. Evaluation. So remember, why did you get it? If they got it for pain, are they in absence of pain? If it was for the procedure, are they having pain during the procedure? Because I gave it to you to not feel pain for a reason. We're going to need to make sure that we sanitize our hands before and after the administration of the topical anesthetics. because again, with that topical version, you're going to put a film or paper on top of it, and then it's like smothered in this area, so everything's being absorbed. So if there's a cut or anything that's there and you're introducing germs, it's going to be absorbed into that cut, and then oops, they have an infection. So make sure that you're being very mindful of this. Notify your doctor or primary care provider, nurse practitioner, whoever, if they do have any signs and symptoms of infection, if they have pain or sudden weakness to their extremities, especially in the epidural route, or decrease in bowel and bladder control, because there's a nerve that was affected that shouldn't have. And then a systemic infusion, watch for metallic tastes, ringing in ears, perioral, so around the eyes, numbness, and seizures. This can be not good. Again, stopping that nerve endings. Your textbook for chapters 35, 36, 37, and 38 were used for this presentation. If you have any questions, please write them down, bring them to class, and we'll have time to go over them on Monday. Thank you. Bye.